Our first speaker for this webinar is no other than the president for the Society of the Brazilian Society for Trauma. He is also the head surgeon of the Hospital Heralde Etape Cherica de Xera. He is also the chef de equipe do Serviço de Emergência de Santa Casa at Sao Paulo, and also the professor of the Department of Surgery in Santa Casa de Sao Paulo School of Medicine. He is from Brazil to give us a lecture on the damage control, its history and concepts. Professor Tercio De Campos.
Hello, I'm Tercio De Campos. I'm president of Brazilian Trauma Society, and it's a great honor to be part of this meeting. I'm very happy to meet you through the internet in the other part of the world. I'm very happy to talk to you about the damage control. I'm starting sharing my screen. First of all, I'd like to talk about the concept of damage control. It comes from the United Navy. That's the capacity of the ship to absorb damage and maintain mission integrity. This is very important with our severe patients, that they can arrive safely in the end of the course. So, emergency control without definitive repair in a situation that threatens the ship and its ability to fulfill its mission. Performing immediately life-threatening procedures on patients with metabolic disorders. Allow time to treat coagulopathy and perform complete resuscitation to allow the survival of patients who would previously die. I believe the first concept of damage control comes from Professor James Pringle in Glasgow, that has been published in Annals of Surgery in 1908. Then he described 8 patients with severe injuries in liver and described each patient, what happens with each patient, and to develop the concept of in Pringle maneuver. So that's a very important and interesting paper that I recommend you to take a look at this. I believe this is the first paper describing the concept of damage control. It comes as well from the military experience, especially in Second World War and Vietnam, where this practice has been discouraged. However, 20 years later, Shafton et al. Described better results in resuscitation patients when they had damage control in liver injuries. About 15 years later, 4 cases with massive bleeding from the liver, temporarily controlled with packing, allowed safe transfer for definitive treatment in most appropriate hospital. So at this time, the concept has been started the way we know nowadays. In 1983, Stone popularized the technique of stop laparotomy, established intra-abdominal tamponade, definitive correction of the surgery afterwards when the coagulation returned to an acceptable level, proved to save lives in previously unacceptable situations. In 1993, Rotondo et al. They have described a recovery rate of more than 70%. And damage control due to abdominal vascular injuries with massive shock and hypothermia and acidosis has been established. We can see here in the last decades of last century a lot of papers describing damage control techniques. So this concept has been established, and how we know it nowadays. So we have to keep the patient alive. And we have to know as well that the lethal threat, hypothermia, acidosis, and coagulopathy in a patient with multiple lesions is often lethal. Ferrara et al. Reported 90% of mortality in patients with these findings that require massive transfusion. Reheating, replacement of clotting factors, and resuscitation of fluids and blood are critical to combat this condition. Originally used in patients with penetrating abdominal trauma, currently with thoracic, vascular injuries, and fractures, the damage control concept has been established in a lot of different situations. We have three pillars to develop the concept of damage control. Control of bleeding and life-threatening contamination, complete resuscitation and correction of physiological disorders in the ICU, and definitive treatment of injuries. It's not possible to talk about damage control here in Brazil without talking about Professor Carlos Mesquita. He's a very important man in this country. He came here to Brazil and he brought the DSTC course. As you know, all over the world, especially in Asia, and he first doctor to bring it to Brazil was Carlos Mesquita. He's a very important man here, and he told us that physiology is more important than anatomy. This is very important. And another concept very important is to listen the patient's cells. That is very important as well. First time I had a wonderful experience about this course was in Coimbra, when first met Professor Binterk, and we are other Portuguese friends, Carlos Mesquita on the right, Pedro Ramos in the left, and Luis in the left, also from Madeira in Portugal. This was a very important meeting about trauma and damage control concepts that we developed here in Brazil. That's the opportunity that we had in Singapore in 2013, and of course, and this is in São Paulo, Brazil, at home in 2015. So the concept of damage control had been developed here in Brazil, and it's very important. I appreciate the help of Minterk, Pedro Ramos, Carlos Mesquita, and other friends from all over the world. And this is my friend and mentor, Professor Raul Coimbra, and at Santa Casa School of Medicine in São Paulo, when I had the opportunity to work with him in damage control techniques, where we could teach students that deal with trauma. It was an unforgettable meeting about training surgeons, young surgeons, and spreading out the concept of stop the bleeding, control infections, and keep the patient alive. So we have 5 stages in damage control resuscitation. So the selection of the patient, that is very important, the resuscitative laparotomy, the restoration of physiology, definitive surgery, and abdominal wall reconstruction. Damage control is damage control resuscitation and damage control staged surgery. Both concepts we have to consider. And I had to bring this slide from the STC course. That's a very important course for us. So patient selection, I believe that's very important. That's the main part of the old concept. So instability is the main important factor that we consider to a patient to damage control. Inability to have definitive surgery, injury inaccessible at that time, non-operative treatments, embolization, length procedures, for example, WIPO procedures, need for reassessment, for example, intestinal ischemia. Very important to plan ahead. If you don't plan, you don't have the full treatment happen accordingly. So we have to have in mind the lethal treating trauma. We can have these three important factors: that's hypothermia, coagulopathy, and metabolic acidosis. Hypothermia. So we have the heat loss starts at time of trauma and continues in trauma room. Patients naked and completely exposed. So temperature loss occurs in up to 92% of patients. And clinically significant hypothermia, we have the core temperature less than 35, and temperature less than 35 is associated with the need for early packing. So it's very important to control temperature in admission room or emergency room. 21% of all severe trauma have hypothermia. 46% of trauma victims requiring laparotomy, they have hypothermia. So these patients need more fluids, transfusions, and vasopressors. These patients have more organ dysfunction, mortality, and more time in ICU. And this reflects the magnitude of the original lesions and associated shock state. Acidosis contributes to bleeding due to coagulopathy, which worsens the state of shock. So we have to correct acidosis. The best way to correct acidosis is to control the bleeding. And we have to make an optimization of oxygen supply, and blood transfusion is very important. It's key to these patients with severe shock and pharmacological increase in cardiac outputs. Coagulopathy is very important as well because it leads to dysfunction of the intrinsic and extrinsic coagulation cascades. We have platelet dysfunction as well, and weak correlation between platelet count and continuous bleeding. Patients with massive transfusion must be considered, because we cannot believe only in the number of platelets, because its function is not very good. If you have available, we strongly recommend a thromboelastogram, because you can see what's happening in coagulation of these patients. It's very important to you can direct your treatment, so what in the point that's worsening the patients. Transfusion is key. A lot of papers have studied the role of transfusion in trauma patients. So in the last 20 years, it's very clear that the use of blood in patients with severe shock it makes a difference. So in 2000, benefit for increasing the proportion of plasma and platelets in massive transfusion protocols has been determined. This paper in 2013 showed that higher plasma and platelet rates demonstrated survival benefits in the first 6 hours, and proportions less than 1 to 2 were 3 to 4 times more likely to die than patients with proportions greater than 1 to 1. And 2015, the proper study showed that 1 to 1 to 1 should be the better option to patients with severe shock. Tranexamic acid, it's very important as well to patients with severe shock. The CRASH-2 study is a remarkable study that showed a large randomized control trial in 40 countries with more than 2,000 patients studied. Study administration of 1 gram of tranexam acid for 10 minutes, followed by infusion of 1 gram for 8 hours in the 8 hours of the injury in adults and trauma patients at risk of significant bleeding, and associated with a reduction in all-cause mortality. So that's a very important drug that we should use. Another study that has been demonstrated that the tranexamic acid improve mortality, improve survival in patients with severe shock and that have received massive transfusion. This is a Brazilian study, it's in Portuguese. 46 patients that had a damage control surgery, and they showed what was the moment of choice when you choose to damage control surgery. Before arriving the emergency room, 2 patients. When these patients arrive at the emergency room, 12 patients. In this beginning of the surgery, 26 patients. After the patients had worsened during the surgery, 5 patients. Any other moments, 1 patient. So most of patients had a damage control surgery determined in the beginning of the surgery. And why damage control has been chosen for these patients? The number 1 reason was the hemodynamic status of these patients. And the second one, the complexity of injuries. Maybe we should change the way we deal with patients with severe shock and severe trauma. The time of bleeding control is critical. Mortality in patients with severe bleeding that reach trauma center with life, it's more than 40%. And a rapid identification and treatment of severe bleeding is critical to reduce mortality. In traditional US trauma system and Brazilian trauma system as well, the patient moves from the trauma resuscitation department to the operating room or angiography with potential stop for X-ray images, consuming valuable minutes. And in Japan, hybrid emergency systems have been developed. It allows resuscitation intervention, imaging, and damage control in the emergency room without the need to transport the patients to a subsequent destination. High cost of construction and implementation. However, better results, less mortality. And it's easy to understand if you show you this picture. Dr. Coimbra gave me this picture in a visit that he had in Japan about this hybrid emergency room system. You can do anything you want in the same room. You have to move these patients to any other place. This is the emergency room, this is the operating room, this is the angiography room, this is the CT scan room, this is the all room. It's a great benefit for this patient that has a severe trauma. Next step is laparotomy, and we have to control bleeding. That's very important to control bleeding and avoid infection. To control bleeding, the surgeon, many times, he has to make a decision. A decision is to ligate or not to ligate a vessel. And here I can show you this paper. What happens if you ligate determined vessel? And if there is a massive bleeding, I recommend you, in most of cases, to ligate this vessel. You cannot wait for the vascular surgeon. You have to make a decision, and you have to ligate many times that big vessel. Recently, there is a very good idea that this idea gives you more time to control the bleeding or the problem that's happening with that patient. That is Reboa. Unfortunately, we don't have Reboa in Brazil right now, but we have experience of colleagues from other countries in the world. They have used Reboa with great results, and it's a very smart thing to do with patients with severe hemorrhage. Temporary closure that we recommend, especially this picture in the left, that's preferable. These other pictures we have used it more than 30 years ago, and we don't use it anymore. That's the Bogota bag and these clamps that we use it to close abdomen. And this is on the left, and that's what we recommend. Industry has a lot of different products that can give you. We don't have it in most of the hospitals in Brazil, so we use this technique that we make this vacuum, the subside sandwich. ICU is a very important step when we're dealing with damage control concepts. When to transfer to ICU, fast transfer is key at the right time. Premature transfer is not. So we have to control the bleeding. We have to stop the infection and then transfer the patients to ICU. Packing may be unnecessary if coagulation has been improved. And it's very important that surgeon and intensivists, they are playing together. It's not about intensivists, it's not about the surgeon, it's about both of them. That's a very important concept. You cannot only transfer these patients to ICU and come back 2 days later. That's not recommendable. What we expect that happens with these patients: to normalize oxygen delivery, central temperature increase, the pH increase, lactates decrease, base deficit is corrected, and coagulation profile comes to normal. So we can go back to the OR. It's very important as well to control intra-abdominal hypertension, because some patients develop intra-abdominal hypertension. You have to treat it with decompression. When to go back to the OR? It depends on indication for damage control, hemostasis and packing removal, physiological response, the injury pattern, and compartmental abdomen syndrome. Not too early, depends on patient and surgeon and intensivist, and not too late because of infection. The right time. When is the right time? The right surgeon will give you this answer. That's not an easy answer. We hope maybe 48 hours, but it's not to all patients 48 hours. Sometimes 72, sometimes 24. Depends on what's happening to the patient. You have to control mainly this lethal triad. So it's very important to recognize patients at risk. Damage control, it's a very important strategy to deal with patients with severe trauma and severe bleeding. You have to treat the bleeding. You have to avoid infection. These are the two main important pillars in the treatment and decision in damage control situations. Right time to go to ICU and right time to return to OR. And you have to stay with these patients in all stages. That's very important. And you have to work with the other teams. You have to communicate with anesthetic, with intensivists, and everybody needs to know why you're doing that. What's your plan? You have to expose what's your plan. Sometimes they don't understand. So you have to tell them what's your plan. That's very important. Communication is key. Leadership is key. And surgeon is the leader in this moment. So this is very important to have success in damage control techniques. I'd like to thank you very much. I'm finishing with this picture. That's a very important picture to me. I was very happy the opportunity to visit Singapore. It's an unforgettable trip and unforgettable to meet all those friends. And unfortunately, I can be in Singapore or in Asia today, but I'm with you and the other side of the world, and I hope this pandemic finish soon, so we can meet each other soon and talk about trauma, talk about life, talk about friendship. Thank you, my friends. I hope to see you soon.